So why don't we go ahead and get started? There are going to be, I imagine, a few more people trickle in, but in the interest of time and keeping things on schedule, let's go ahead and get started. So my name is Darshan Mehta. I'm the Director of Education for the Osher Center for Integrative Medicine here at the Brigham, and Medical Director of the Benson Henry Institute for Mind-Body Medicine at MGH. And just it's really my honor and privilege to have this phenomenal group of colleagues with us this morning. And most recently I'm going to be part of their team as consultant to the home base program at Massachusetts General Hospital and Red Sox Foundation. So we have today Peg Harvey, who is the director of the intensive clinical program for the home base program. Louisa Sylvia, who is director of health and wellness for the home base program, as well as director of psychology for the bipolar program at Mass General, and Miranda Dahl Vicens, who is the medical director for the home base program and also based at the Center for Anxiety and Traumatic Disorders. Right. All right, we got it. And they may have other roles that I have not mentioned as well, so my apologies. But and they're going to be discussing a case out of a newly implemented intensive clinical program that is based at the home base program, which they will describe. So before we begin, I just wanted to remind everyone we have two exciting seminars upcoming. One. This Thursday, John Denninger, who is the Director of Research for the Benson Henry Institute for Mind-Body Medicine, will be presenting at the Integrative Medicine Research Seminar, which is just down the hall here at the Brigham, at the Shapiro Breakout Room from 4 to 5 on Thursday afternoon. And then our next Integrative Medicine Grand Rounds, which is on Tuesday, February 2nd, will be the team from the Brigham talking about contextual cognitive behavioral therapies for patients with medical illness and depression, and the 3 acceptance-based CBT approaches. So, which will be presented by Abby Altman, Sonia Machman, and Megan Searle, and the discussant will be Megan Oser at the Brigham. So with that, I will introduce Peg Harvey.
Thank you. So it's a real honor to come here and speak about our new program. We're really excited to be offering this, and it's kind of new to us as well. So we're in a process of evaluating how we're doing, what we're doing. So an opportunity like this really helps us gives us an opportunity to stop and think about what we are doing. So, oops. All right. So. The plan today is just to start with a patient overview. So we've identified one of the patients that went through our pilot program in September. We had 5 patients in total, so this is one of them. So I'll go over some information about him. Then I'll discuss the intensive program in general, and then we'll kind of hone in a little bit more on the integrative therapies. In particular, Dr. Sylvia will talk about Resilient Warrior, which is a component of the intensive program. Then Dr. Nadal will talk about pharmacotherapy that this patient had, and then we'll kind of in general talk about his response to treatment and kind of be done at that point. So the patient's a 48-year-old male, active duty Army. He was a soldier. High-ranking officer. When he came to us initially in, end of August, I believe, is when he first presented to the clinic. He was still active duty, and during the intensive program and then afterward, he went through the discharge process. So at this time, he is discharged, but months ago he was not. And he did go through the medical discharge after 31 years of service in the Army, several deployments. Bosnia, Kosovo, Kuwait in 2003, Iraq in 2009, 2010, 2012, 2013. Kind of repeated combat exposures, and not always like himself kind of engaged in combat things, but he was in a role where he would evaluate situations afterward. And that was one of his primary traumas, was, interestingly, not something that he was engaged in firsthand, but something he had to evaluate. And so a little different kind of type of trauma, if you will. He also had PTSD from childhood. He endured some physical abuse at a daycare center and was kind of dismissed by his parents about it. So, emotional traumas related to that as well. He also experienced military sexual trauma when he was much younger in the Army. And he kind of described how that, often kind of set the tone for some of his other experiences. So it's kind of typical to see this kind of myriad of several traumas that these folks experience. And, it helps, it really points out to us how, sure, we many people experience trauma, but when it is, there's multiple types of traumas and multiple traumas for a single person, that's often what will develop into more of a PTSD that we'll see. So this gentleman, in addition to these kind of traumas he experienced, in 2005, he was diagnosed with a brain tumor, left optic nerve glioma, and he went through 2 years of radiation and treatments. Also had spinal meningitis at that time that kind of complicated his treatment, and as a result, he has permanent loss of vision in his left eye. So if you notice the dates there, he was deployed twice after that. He also had a heart attack during this time, too. I think we forgot to add that one. There's so many things going on with this guy. So I think in 2009, I want to say, he had a heart attack as well, had stents put in, but again, deployed after that. So obviously a very resilient person, and someone that is able to, manage issues like this and still kind of soldier on, if you will. Again, a very common characteristic we'll see in these folks. So as a result of all this, he did notice some kind of mild cognitive impairment that was diagnosed in 2011. And throughout this, too, just managing kind of chronic pain from spinal stenosis and bilateral carpal tunnel that I think he's getting surgery for pretty soon, actually. So more on the mental health side. Depression was a significant concern, as well as substance use, drinking in particular. So he had 3 suicide attempts in the last 5 years. The last one was in March, where he mixed alcohol with medications, and that resulted in hospitalization. I think the other times also was a similar pattern of alcohol and medications. So September 10th, he presented to home base for his initial evaluation. And I believe at that time we were looking for patients for our pilot, and he seemed like a really good candidate. In particular, he, had the time to come. So our program is a 2-week program. He, was interested in it, and very much at this point in his life where he wanted change, and was willing to work really hard for it. So at baseline at that time, his PCL or PTSD checklist, version 5, was a 65, which is suggestive of severe symptoms. And if to look at the actual items he indicated were concerning to him, it was a pretty broad range of PTSD symptoms. But his primary complaints were sleep problems, distressing memories, avoidance, and emotional numbing. And then emotional numbing was affecting his marriage. He was somewhat recently remarried for the 3rd time. He'd been married about a year at this time, but been with that woman for I think 3 or 4 years. So he was concerned about how it was affecting his relationship. So as I said, co-occurring depression and alcohol use. It was severe, but in remission. He was sober since April, and he recognized that his alcohol was related to his PTSD, and it was a way that he was coping with his PTSD symptoms was through alcohol. So been sober, like I said, since April, and a very strong proponent of AA, attending pretty regularly, had a sponsor, and he really took that very seriously, recognizing that if he wasn't sober, he couldn't work on these other things. So, that was really something that was really in our favor as treaters, because that can be so challenging to help a person even recognize that and then, reduce and stop their drinking, or at least reduce it to a point where you can work on the PTSD side of things. And so that was a big plus for us as far as being part of his treatment team. Let's see. So in the past, he had done residential treatment for alcohol and PTSD through the Department of Defense. And he was starting to kind of, like I said, get a handle on, how his issues were coming together, what he could do differently. He had done some exposure-based treatments on his trauma, so talking about what had occurred, but no real formalized treatment. Like I said, he was very active, very motivated for treatment. His wife also was very active, wanting to help as much as possible, but also concerned about their relationship, and sometimes feeling like she was at her wit's end with the emotional numbing and sometimes anger that he exhibited. So we referred him to the intensive clinical program that ran from September 28th through October 9th. So patients arrived on Sunday evening, actually, and completed measures and such. And then Monday was when they started treatment for the 2 weeks. In addition to that, or as part of that, he also received individual therapy. That was I was his therapist, and then medications with Dr. Nadal. So to talk about the intensive program. So through the years, so home base has been around about 6 years, and prior to that, I worked at the JPVA right here for about 5 years as a staff psychologist, working with this same population, so veterans of Iraq, Afghanistan. And I, as well as others, my colleagues, we recognize that these patients, while they do have somewhat typical, if you will, PTSD, that even typical PTSD really requires a broad range of care and services to address different symptoms that might be presenting, or to help a person recognize what's going to help them. Not every patient is ready for prolonged exposure, which is a very effective exposure-based treatment for PTSD. We do try to get them to that point where that's what they can do, because we really feel like either that or cognitive processing therapy, which is another exposure-based treatment, are very effective at treating PTSD. But a person has to be feeling good about their preparedness for that. So looking at what else can we do for a person in 2 weeks to kind of wrap around them and get them prepared and feeling safe about doing this intensive treatment. So myself and several of my colleagues kind of worked through what we thought would be helpful, And as I said earlier, this is constantly being changed. But so at this time, the intensive program involved, comprehensive evaluation, individual treatment, group treatment, medical, medical evaluation, pharmacotherapy. But then also, we wanted to include stress management, resiliency training, fitness and nutrition, integrative therapies like yoga, art, Tai Chi, and then a real important part is to include the family. So each person that is coming for the intensive program identifies a family member that either is able to attend with them or that we can at least communicate with and perhaps do telehealth with, so somehow involve them, the family members, to understand what kind of care their loved one is getting, but then also to understand how PTSD and deployment-related issues affect relationships and parenting and things like that. So what I realized is I didn't say that so the program accepts patients from anywhere around the country, and we're fortunate enough to have support, philanthropic support, to provide transportation, lodging, food to all these people. We're working toward a maximum cohort of 10 at a time. And so another important part is the social activities, for various reasons. Some of it can be just to keep people active, because there's, we have a strong concern around downtime. And if these are folks with histories of substance use and, behavioral problems and such, that, keeping people busy can limit problems. So social activities are important, but it also gives people opportunities to try out what they've learned. So some of the groups focus on approaching situations, not avoiding. So like in vivo exposure groups that that will encourage people to go and do things that they might feel anxious about. So the social activities gives them another avenue to go and practice those things. So throughout the 2 weeks, so it's a 2-week program, and throughout that time we kind of tallied this up. I recognized that they get about closer to 40 hours of group treatment in this time, about 8 sessions of individual therapy, 6 to 8 hours of case management, which is really important because we recognize that, sure, you come to us for 2 weeks, we do all this stuff, but then you need to go home and continue doing a lot of the things that worked for you, or even try something that we feel like is your next step. And we do a lot of work to kind of find those resources in people's hometowns or close by and connect them with that care before they leave us. So the case management is really critical. And then about 12 hours of integrative therapies. So throughout the 2 weeks, they got 5 hours of yoga, 4 hours of Tai Chi, and 3 hours of art therapy. Now, as a CBT psychologist, I admittedly wasn't sure about how much the yoga, Tai Chi, art therapy, how effective those things would be, how helpful they would be. And it was really remarkable. And as with this population, so we had 4 men, 1 woman. They're all combat veterans, all been to Iraq or Afghanistan. And, you just don't know how these, alternative things could go for these people. And I must say they were very willing to try things. And we kind of let them know that there's going to be different things that you've never tried. And we want you to just be willing and open to give it a shot. And they really were. I think especially the yoga. So they did yoga nidra. So, with sleep being a primary concern for these people, they called it sleepy yoga. But, you can imagine, after a couple times of doing this, that, an hour or a half hour or so into it, there's 5 combat veterans asleep on the floor. These are people that don't easily go to sleep. So, and they were just like, wow, they were so hopeful. They recognized that, there's things they haven't tried, and you can get good outcomes from new stuff, and you got to give things a try. So even just that mind shift for these folks was really important, I think. It really kind of gave them hope. So then, like I said, the family came for an abbreviated time, and this we kind of worked on, especially in the beginning. We weren't sure if we really wanted family members to be there for the full 2 weeks. We weren't sure really how complicated that could make things. It could be good, it could be bad. So the family members arrived Wednesday evening and stayed for treatment Thursday, Friday. And during that time, they had a lot of educational groups around PTSD symptoms and treatment, traumatic brain injury as well. So this first cohort was primarily PTSD. We are working toward having more traumatic brain injury patients. But some of them did have co-occurring mild TBI. Let's see. Other educational groups were around how to help a loved one with substance use problems. And I'm trying to remember if we were working toward having the family members do a version of our Resilient Warrior that Dr. Sylvia will talk about. So recognizing that, while families, the education about what their loved one is going through is important, but also helping them to see how they can help themselves, learning their own stress management techniques, things like that. And for the family members, it was kind of a shift, and we really had to push them to see that, you need to take care of yourself. It's not just all about the veteran. And what was really nice is to see the family members with other military families. I guess there are other opportunities for that to happen, but it just so happened that these folks really hadn't done that yet. So I was in one of the groups where, they had done, the veterans had done this mask project in the art therapy that is becoming very common with combat veterans, where they basically, they already have a mask, so they don't have to make the mask, but I think some programs you do actually make a paper mache mask or something. But but they decorate it with things that are kind of like expressing how they feel about themselves or how they think other people see them. And then they shared that with their families. We had one group where the families and the veterans were together. And it was great because it gave the veteran like something a little external to describe how they are and how they feel, rather than saying, I feel this way, or this makes me angry, or whatever. You know, so it really helped them to share that with their loved one, but without having it to be like so focused on them. So it was really great. So the one part I have left out a little bit is the resilient warrior component. So Dr. Sylvia, come talk about that.
So I always like to bring props. So here's my prop for today. This is the manual that they get. They actually did a great job of putting together a huge manual or sort of procedures that everybody gets, a workbook, if you will. And this is one component. And in full disclosure, we really struggled with trying to figure out which components of this program to highlight. As Harvey sort of walked through very nicely all of the various components of the program. So figuring out where is sort of the core pieces as it relates to integrative therapy and integrative medicine was a challenge. And so we picked this one program, but again, there's 12 other hours of Tai Chi and yoga and art therapy, so I'm glad that Harvey walked you through that. But I do want to talk about this one particular program because this is also a standalone program that we do in the community as well, and I would love input from this group when it comes to question and answer time on things that you like, don't like about the program. We're constantly developing it and redeveloping it. It's a collaboration between the home-based program as well as the Benson Henry Institute for Mind-Body Medicine. So it's been a lot of fun for me. I'm also a CBT-based psychologist, and so getting into sort of the integrative medicine and therapy world has been very fun for me, and getting trained with the colleagues over BHI has been great. A little bit of very quick background. I'm sure this is your bread and butter stuff for this crowd. You know, mind-body pieces, the importance of how stress affects the body. I love this concept of allostasis, or I think this really kind of creates the background to mind-body medicine. This idea that our perception, our mind, as it relates to how we see life events, which particularly when you have a traumatic event in your past, your perception becomes distorted. So there's this mind component, but there's this very real body component. Again, I think as a psychologist with sort of the CBT backing, the body component, I wish we had more training on this physiological response, because we know it's there, we talk about it, but we're not taught meditation and prayer and yoga and Tai Chi and other ways to sort of refocus our body and our body's responses in a way that I wish became more a part of at least my training and background. So again, it's been nice to have the opportunity to do this later in my training, but I wish it was more a part of the integral pieces of what we learned as it relates to working with patients. So we have these mind-body components, and what Resilient Warrior really tries to do is to focus on both. And I will very quickly walk through the program. But again, this may be something you're very familiar with or not. This is the concept that when we don't adapt well to stress, what can happen? So, you know, if you have repeated hits or exposure to stress, you can see that, you know, that sort of your stress response goes up and goes down. Over time, an adaptive way to manage stress would be to eventually, and it's tough to tell, but in the second, I think I have a pointer here. Yeah. So, I don't know if that's working, but there we go. Okay. So up in here, these little triangles here show that over time, those hits would become minimized, and they would eventually go down. So when you're exposed to stress, your spike wouldn't be so high. But in the folks that we're working with, that doesn't happen, right? They often stay more often in this hypervigilant zone where they experience a stressor and they stay quite stressed. You can also have this sort of blunted effect where you experience a stressor and you don't have a response. You don't have an adaptive response that you would hope if you had a stressor coming towards you, because there is some adaptation to experiencing some stress. But these are some of the ways that we see our veterans struggling with stress management, and hope through Resilient Warrior and mind-body programs like the ICP to better help them manage so that they can become like these little triangles going down over time. I love this slide. I stole this from BHI. This is one of their core slides. It shows quite literally, if you're hooked up to a blood pressure cuff, what can happen when you are first at baseline. So you see the baseline coming down to about 95. And then what happens just when talking, how your stress goes up and how quickly it can come down in this C section here. When you just practice a little bit of meditation, maybe a few deep breaths, and then when you do a math problem, subtract by 13s. I'm telling you, it's a lot harder than you think. We become a little bit stressed. But then when we meditate, and it's, again, this is a general term, it could be deep breathing, it could be some quick guided imagery, and then, putting your eyes, so again, you see what happens, right? This idea of how we get stressed over time and how quickly meditation can really help to manage this physiological response. Okay. So, again, hopefully this group is well aware of all of the effects of stress and what we call eliciting the relaxation response or practicing meditation or any of these types of strategies to help elicit the relaxation response can do to our bodies. All right. I'm going to give a really quick overview, mostly because I selfishly get feedback from this group on, again, things that you think we should add in or any feedback that you have in the course, and I'm happy to speak with people more after this if you have questions or want to learn more about this program, because it is, again, a work in progress. So the first class is mostly educational. I gave you a little bit of a primer, actually, on our first class. We do the energy battery, which you write down things that cause stress and things that help you to manage stress. Class 2, and I should mention, every single class does an in-session practice eliciting the relaxation response. This is really important because a core component, again, the Benson Henry Institute is really paving the way in this way in terms of saying you really have to have an experiential component to doing this work. We really want people to actually practice doing this. If I was doing a 2-hour intro to resilience training with you guys in here today, we would close our eyes and do some deep breathing, and I'd really have you guys try and experience what we're actually talking about here, because that really is the best way to really understanding what we're talking about here and to start to get some practice, and that's very important. So every single class, as we call the RR practice, in the first one, just to reiterate, we actually do a body breath awareness, so deep breathing. And this one, we do a body scan. We go through all the different parts of the body and tense and relax the muscles so you can feel what that physiological response feels like, what tension in the body feels like versus relaxing. We go through minis, which are little ways like counting backwards from 10. Again, 3 deep breaths. These are little teeny 5, 15-second ways of eliciting the relaxation response. Then we talk about barriers to practicing the relaxation response. We've got lots of those amongst our veterans. As Peg Harvey said, we have some, what I call healthy skeptics sometimes amongst our veterans about, I don't have time to do deep breathing or meditating, prayer. But we talk through it, and I will tell you, I absolutely agree with Dr. Harvey about this, that the veterans that were in the program, and I do this program within the community, they go from being healthy skeptics, I would say, just to at least being open to trying it, if not really being true believers. And I think it's, again, part of this practicing in every single class that helps. Obviously talk about sleep and sleep hygiene and sleep tips. We talk about the importance of social support, and we also in this class do a mindful eating exercise. So it depends on the food that we'll sometimes do, but it tends to be focusing in on eating something, not necessarily the raisin, which is a sort of popular mindful exercise, but something along those lines. And then we also do this, what we call the social atom, which is helping people understand who in their lives are giving them stress. So the arrows that go towards me are the people who are giving me stress, versus the people who are taking stress from me or helping me to manage my stress. And those are the people, those are the people who I'm giving out to, those people who are actually causing more stress. People coming into me are the people that are helping me manage my stress. Class 4 is awareness of movement and how movement can help with managing stress. So we do a very low-intensity yoga practice. This is in addition to the yoga that they're getting, sleepy time yoga that they get later on in the afternoon. This course is offered the first 2 hours of 3 of the 5 days that they're in the program. So it's there's 10 days that they have programming, the 2 weeks, 5 days each week. And this program is offered the first 2 hours, Tuesday, Wednesday, and Thursday. But later in the day, they also get more yoga practice. What's done as part of this course is essentially a seated yoga, mostly stretching. But then we also start to deal with the mind components, if you will, of the stress response, which is how we perceive stress. And this is sort of a more standard, if you will, for, again, us CBT folks doing cognitive reappraisal or cognitive restructuring. We start that in class 4. We complete it in class 5. I'm sorry this is really close, but for those of you, this is going to look like old hat if you're familiar with cognitive restructuring, but it's identifying your physical signs, emotions, and thoughts that go with it, and then identifying evidence against those thoughts. So again, trying to understand how to reinterpret your environment in a more adaptive and helpful way. And then we also talk very briefly about exercise and diet. We throw the food pyramid up there. I recognize it's not enough, but we also have nutrition, and we also have a fitness component that we're going to pilot as part of our next program. We'll be working with an exercise physiologist. So this is, again, a little teeny primer as part of the Resilient Warrior course about how exercise and diet can help to cope with stress. And then they get more elsewhere in the program. The last class, we do a longer meditation. I will say that the RR practice becomes a little more in-depth with each session. The last one is about a 15 to 20-minute meditation exercise where they're contemplating their goals and aspirations. And then we also wrap up with talking about effective communication and strategies for staying resilient. So the idea is, again, that they get at least 5 minutes and up to 20 minutes each class actually doing some form of eliciting the relaxation response in class. We do have just some very early pilot data. This is actually not based on the intensive clinical program. We did not, because Resilient Warrior is embedded with so many other areas and so many other strategies and interventions as part of the intensive program. We haven't looked at the RW data in any specific way. This data is pulled from when we do it in the community. So these are individuals who sign up to do our community program, and they just come to the Resilient Warrior, and it's actually a weekly intervention opposed to 3 days, sort of back-to-back days over 2 weeks. A very small sample was just recently published in the Global Advances in Health and Medicine, about half female, mean age 36, mostly married, most have been deployed, and about half were on active duty. I actually highlighted, this is just our pilot data, I actually highlighted the one that looked the worst outcome, which is our resilience scale, which is unfortunate. All of the others were either significant or approaching significance, which for a small sample was good, and the effect sizes of Cohen's D there are pretty good for those. But for some reason, the resilience scale, and we've been contemplating this a lot, why we didn't see a larger effect there. And I think it's in part, resilience is sort of how your overall mastery of life and life stress, and I think it's something I'm hoping that starts to change more as you practice the skills taught in Resilient Warrior, that over a 5 or 6 week period, we just don't see big changes in resilience. But, you know, I highlight that in red because that's something that I'm thinking a lot about, and again, welcome other people's thoughts on that. But that was the one outcome, resilience program. We didn't change, it didn't change resilience, but again, I think the other indices of depression, perceived stress, general self-efficacy, and anxiety all improved and were in the right direction, so that was good news. And with that, we don't have to read my dialogue.
So just to highlight, our program, our intensive clinical program, combines all of these different things. So Resilient Warrior is lots of hours of programming embedded in with encouraging them to focus on practicing yoga and Tai Chi and meditation, and practicing and the group exposure therapy. And then in addition, there's a lot of individual work. So as we sort of said, our patient here did 3 to 4 times a week with Dr. Harvey, working on prolonged exposure to try and overcome the PTSD, as well as meeting 3 times a week with me to go through pharmacotherapy. So trying to use this intensive program a little bit like we would use a hospitalization to combine these individualized, tailoring individual treatments to address their particular concerns, in addition to all these group exposure activities. And then what's also individualized is, as Dr. Harvey mentioned, is the case management component. So we introduced them to about 8 different approaches during this program, and then we would choose, the case manager would work with them, the social worker, to really identify the 2 or 3 that are going to be pivotal for them to keep going forward on in their home community, and what treatment approach is going to be most effective for them. So just to sort of say, we're attacking it from all angles. Just to give you an introduction to pharmacotherapy, we sort of try and do a lot of medication changes. It's not an inpatient program, but we do sort of rapid medication changes because they're staying with us at the hotel. We're seeing them first thing in the morning. We're sort of programming them all day, so we feel like we can adjust medications pretty quickly and introduce new medications, get levels, and have them leave in 2 weeks on a sort of totally revamped medication regimen if we feel the need for that. So our particular patient that we introduced you to, medically sort of complicated, has the really intractable PTSD, and for him, he did not have a history of bipolar disorder, but he really had a lot stemming from his PTSD, a lot of irritability. So he would lash out at his family. Obviously, his long history of pretty intensive drinking and alcohol contributed probably to the irritability. We were seeing him sober. So we were fortunate to see someone who was, at that point, he was 5 months into his sobriety, had really sort of taken to heart the AA and for him the religious component and the prayer component to it. But despite all that, continued to have quite a bit of irritability. So his goals as a pharmacotherapist, meeting with him, he really had a lot of difficulty sleeping, and so his sleeping was primarily obviously contributing to his irritability. His outbursts with his wife and his children, to the point that he was sometimes even worried his children were scared of him, and these sort of outbursts, despite the fact that he really is a lovely man. And then the PTSD symptoms. So 2 birds with 1 stone, Depakote, using it for sleep and increasing. So he was on a Depakote regimen that was distributed throughout the day, so we redistributed, increased the doses, and redistributed more towards nighttime. He had not been on gabapentin. He had considerable anxiety. He actually had some anxiety about just different types of exposure situations, obviously with his alcohol history, avoiding certain types of medications, but the gabapentin actually proved to be quite nice for helping him with falling asleep and then indirectly with nightmares. So nightmares, we primarily used prazosin, which was had a very nice response for him in decreasing these PTSD nightmares, but the gabapentin may have contributed as well. And then he was on a lower dose of sertraline for his PTSD. So we know, particularly in these military veterans, we know for anxiety disorders and PTSD that the dosing of the sertraline needs to be higher. And with these veterans, I have had veterans on 300 milligrams a day of sertraline. So really sort of pushing those higher doses. Once you get up to the higher doses, I usually do combine that with getting blood levels to make sure that we're not that we're somewhat in range, but it's not uncommon to require these higher doses of the SSRIs to really try and get at their PTSD. So we were doing the medication changes at the time that we were introducing them to a lot of these different approaches to reducing stress. And the key, in terms of where this patient was at the end of his therapy, at the end of his 2 weeks. So he was now finally ready to tackle really intensive therapy. So what our 2-week program was really pivotal in doing, we took someone who was already quite ready. So as I said, we got him sober. He came to us sober. He came to us very motivated, and he came to us with somewhat of an open mind to wanting to try new treatment. So we were lucky, so we could take someone who was really quite on the brink of change. And what the ICP program was very helpful in doing in terms of keeping in mind with all these different integrative approaches is allowed him to tolerate the distress that comes from the work he needs to do to get better. So he was finally able at the end of the 2 weeks to really start a more intensive program, has continued to work with Dr. Harvey to do some very intensive work around his multiple forms of PTSD, both combat-related and childhood-related. But what the program allowed him to do is to tolerate that distress. So in the past, those feelings of emotional distress caused him to run away from that treatment approach. And he became much more hopeful about the fact that it wasn't a lost cause. He came to us chronically, decades into his illness, very rigid illness in someone who was very functional and very resilient, but his illness had been untouched for decades. So his high level of PTSD symptoms, irritability, multiple marriages, estranged children from previous marriages, all of that had, despite his resilience, despite his hard work, none of that had changed for decades. He had given up hope that something could be done for his illness, and in this 2 weeks we sort of turned that around. His final PCL was very, so his PTSD checklist went down from 65 to 17. The PTSD cutoff for this PCL-5 is about 38, so he's half of the level, so pretty dramatic change in his PTSD symptoms with this sort of combined approach. He came to us wanting to retire from the military, ready for retirement. In the time we've been working with him post-program, he's actually taken on a new job. He has retired from the military, but he's taken on an even higher level, job. So not really ready to give up his professional life. Feels like he's got a lot to contribute. Feels like he's got a much better handle on his irritability and his outbursts. And he's become a big fan. He actually, we were hoping we might get him to be a spokesman for our program, an outreach person, but obviously he got snatched up by bigger organizations than ourselves. But he's a big proponent of this sort of integrative approach to reducing stress and coping. And obviously, he is a very big component of AA and maintaining sobriety, but using these methods of, as I said, managing the stress that comes with the work that you must do to make yourself better. That for him was eye-opening, and he has really come a long way. So that's our introduction to our new clinical program, which we're very excited about. We're adding more components, and I'm just going to add this in. We're working with veterans, obviously, with very complicated PTSD, but we're also working with veterans who have multiple head injuries and a lot of cognitive losses. So our program combines, we're now adding a whole cognitive enhancement training for both veterans who have had head injuries and head traumas, as well as for those who just have the cognitive impairment that comes from chronic PTSD and depression. So we're adding that component. We're sort of trying to gear ourselves up to really deal with the complexity in this multi-pronged approach. So we are very psyched we're about to start a whole series of running these 2 weeks programs a little bit more frequently than once a month. So really just cycling through and trying to reach as many of these veterans across the country as possible. For you guys, it's here. But anyway, that is our introduction to the program and to the different Resilient Warrior and all the other techniques we're using. So thanks very much, and we'll take questions together.
Okay. Thank you. Thank you very much for a fantastic presentation. I just want to give a quick preface that this is very unique as a program in the entire country. There is really actually no program like it thus far. So it is really setting the stage for novel innovations and interventions in treatment of very complicated and complex conditions. And the other thing I should just mention is that, as many of you know, the rate of death from suicide is greater post-military as compared to the number of number of soldiers that die while in service in the military. So it's I think a magnitude of 3 times or even more. Is that correct? Right, 3 times greater. So just to give you a sense of the magnitude of this problem and why such type of innovations are necessary. Okay, Helen.
Thank you. That was. Yeah. Okay. I have a question. I understand that obviously you have in 2 weeks to do a lot, and you want to take advantage of it and really use this opportunity to its fullest. I have a question though. Coming as a lab scientist, if you're changing several variables at once, so you're changing medications and then they're introduced to new things that they've never done before, like yoga and stuff, and then the patient over the course of several days get better, how do you know whether it was the medication and whether you should keep pushing that medication or whether it was the Tai Chi or something? How do you unconfuse that?
I mean, we're all very much scientists here. So what we're doing is we're gathering a lot of data. So these poor patients, the one thing we do is throw a lot of questionnaires at them before and after, have their families fill out questionnaires, and then they fill out questionnaires every 3 months afterwards. They rank what they think is most useful. So no, we're not going to get at it other than as Dr. Sylvia did with her Resilient Warrior in an isolated format. We're not going to get at that, but we are going to try to figure out which ones seem the most useful, and Dr. Harvey is continuously modifying how much time is allocated to topics based on feedback.
Yeah, I mean, when the warriors all start with us, we let them know that we are working on this and we want their feedback throughout. You know, even like in the moment, is this working for you? You know, to be in a mixed cohort or what? You know, we really encourage them to give us feedback throughout. But it is a challenge, you know. But we also don't want to like decrease giving them something. You know, we want to give them everything, hoping that something will be helpful. And then, and we're hoping as we run this time and time again that we will collect enough data that somehow maybe we can parse out what is more helpful or effective. And with people coming, they, you know, while we have it focused for treatment of PTSD and traumatic brain injury, we recognize that these folks could have other concerns as well. So we can't just give them everything that's PTSD related. We can't forget they have most likely depression and substance use issues. And, you know, I think our range of treatments is reflective of the range of issues these people come with. So.
And I'll just add, we don't know. So, and this program is not a program to ask that question because we don't know. So what we hope is that other people out there test out Tai Chi and yoga and isolation, Resilient Warrior, and then we bring those components into this program based on the evidence. So, you know, 30, 40 hours of group therapy, 12 hours of integrative therapy. So the reason that they're doing less integrative therapy is there's not as good evidence for trauma as it relates to Tai Chi and yoga. So we're giving them an introduction. It helps for some people, but the evidence is not there to point to it being a larger part of the program. And so the program is constructed based on other evidence that points to how we should do the program. And then we do hope to get some feedback, but it's not a dismantling type study. We would never be able to answer those kinds of questions in this program.
Thank
you. So my question is totally different because I'm not a scientist. I'm a holistic, somewhat trauma therapist. So first of all, I think your program sounds amazing. For me, it is very much the Tai Chi, the yoga, the integrative therapies that are doing that. My sense is, although I can't say I know it offhand, there is quite a bit of evidence about it. The Trauma Center with Bessel van der Kolk has done a lot of work now on yoga at least, and I think there are others. I have a different curiosity again, and again, there is quite a bit of evidence, which is, do you ever use EMDR with your veterans? And I will even go further, and the energy therapies, which just tells you where I am, in these hallowed halls.
Right. So none of our clinicians practice EMDR. We're one of 4 sites throughout the country that have been funded to provide these services, and one of them is Emory, and Barbara Rothbaum does practice EMDR, and she has a group that's going to be doing that there. So we'll be looking at what kind of response she gets, and perhaps we do need to add that in. I do recognize, like we've mentioned, as CBT therapists, we are so tied to our prolonged exposure and cognitive processing therapy. But I think what this program is doing for all of us is opening our eyes to how there can be many things that help. So who knows, maybe in a year we will have EMDR and all these other things.
The first stage of the EMDR is actually somewhat cognitive.
Yes, it's very
cognitive.
cognitive.
It goes from their
Right, and a lot of the research has shown that the exposure component is very, is very effective as part of EMDR. So we're really not that far from it, So yeah, well.
Peg, can you just list the other sort of traditional group-based therapies that are administered in the program?
Sure. So we also have DBT groups, dialectical behavioral therapy groups. That is a real challenge too. So DBT, I'm sure several of you know, it's months of treatment, and you can repeat. This is just the skills groups we do, and those often are repeated by patients over and over again. So you could do a year's worth of DBT groups. And so we're looking, okay, so if we have 8 or 9 sessions of DBT, what would be like, what should we highlight in that? So, but they really were very receptive of the DBT kind of way of thinking about things and looking at ways to manage emotions, and emotions have purpose and all that sort of stuff. Also, trying to remember the group. So DBT, an in vivo group. So while the intensive program, so far we haven't had prolonged exposure in the 2 weeks yet. We are working toward doing that. But I felt that the in vivo component of prolonged exposure, so for those who don't know what that is, so basically prolonged exposure has one part where you talk about what happened, and another part is where you approach the things that you have been avoiding. That's often secondarily to the PTSD symptoms, so something might be a reminder. So like being in this amphitheater might be very triggering for a combat veteran, where you have limited access. If they're sitting in the middle of this amphitheater, they'd feel pretty anxious. So the in vivo group actually gets them to go do those things. So using our environment where the clinic is, riding elevators, going out, walking around the streets with a therapist, and approaching and not avoiding. That's another big part, group therapy, as well as the Resilient Warrior. So those are the 3 groups.
Thank you. That was a fabulous presentation and such a rich program. And I'm a scientist as well, so I'm even hesitant to ask this question about adding new things and building on the EMDR. I'm wondering, given that people come with a lot of chronic pain issues and chronic neuromusculoskeletal issues, especially with TBI, whether your program in the future or some of the other ones that are existing are looking at more passive somatic therapies, hands-on things, Feldenkrais, Alexander, massage therapy, chiropractics, things that we focus on at the OSHA clinic that might be a nice rest from all the work that they're doing themselves, but also just get at these issues from a more bottom-up perspective.
So thank you for that question. And this gets back to time, a lot of time, and then a lot of just concern about doing sort of sensory motor kind of touch therapies for a group that has a lot of trauma. And without being able to do that in a group setting, how do we do that in an individual? And there was just a lot of logistics around that. But an excellent point, and I wish we could get more in. You have to talk to the director over here.
Yeah, I definitely agree. It's tough, though. I mean, I create the schedule over the 2 weeks, and and this is one of the complaints from the patients was there's so much to do. We don't have enough breaks, and it's tough to put all these components in. But I think also what we want to do is perhaps give them resources about these things. We're looking at ways that we recognize there's so much that can be helpful, and how can we give these people information about that. And we're looking at a platform that will help us we could give resources to these other forms of treatment, and even videos of people describing how it's helpful and things like that, where we may not have the hour to dedicate to the actual treatment, but we could at least inform people about them. I think one of the things we are looking to add, hopefully, is acupuncture for pain. Pain is definitely a significant issue for many of these folks. I mean, even if you've just done a typical 4-year tour in the military, you've half of that was probably spent with a 50-pound pack on your back, which, I can only equate that to being pregnant. Luckily, I didn't, gain quite that much, but you recognize, like, when your body is, like, stressed with all that, even just weight affects your knees, your back, So these guys have a lot of orthopedic complaints, and pain, is very close with that. So, there are CBT interventions for pain that we'd want to also add in. But again, it's just a matter of when and the time really.
Hi, my name is Rick Leskowitz. I'm a psychiatrist at Spalding Rehab Hospital. I work in the pain management program and head the integrative medicine project there. So a lot of overlap between what you guys are doing and the last two comments, as well as what we do. And I just want to thank you for the work that you're doing, because it's really pulling together some really important components. I just want to say that there's a strong similarity between what we do in our program and what you're trying to do with your folks, in part because so many chronic pain patients have a PTSD trigger to the thing, whether it's the industrial accident or the car crash or whatever. So a lot of parallels, and be glad to talk with you about how we've integrated some more pain-specific approaches within a very similar framework. One key addition I would like to point out, though, going back to the holistic practitioner over there, is that an adjunct of these, it's really an exposure desensitization protocol, but it has a somatic component that involves acupoint stimulation. It's phenomenally effective for the PTSD elements. There's a strong research literature. I'd be glad to pass on some references. And it's also can be implemented by coaching from peers. It doesn't have to have a scary doctor in a white coat kind of thing that just a fellow vet can teach it. So there's some really effective impact from that alone as an adjunctive therapy. So good work.
Yeah, we would love any resources you guys want to send to us. I'm sure that you'll get our contact information, and that's a lot of what we do. We I'm not sure who's heard of Home Base, but we're much more public than other kind of mental health providers, and we get lots of people contacting us with different, oh, try this, or we have this resource for you, and this and that. So we're always open to ideas and funding.
Great.
I also want to thank you for the presentation and the work, and it is very exciting. Many things are very impressive. One that particularly caught my eye was this differentiation in the people, this man you're presenting, where I think it was your presentation that said he had begun to appreciate the reactivity in himself, or the struggles in himself, as part of the work he was going to have to do to continue to get better. Because I think often a PTSD patient, particularly with one that starts in childhood, will view any conflict or difficulty as a recrudescence of the PTSD, and they get stuck in this loop where they want stuff that's going to make the symptoms quiescent, and it keeps them from doing the work to get better. So I'm curious how you think about how that happened. And my hypothesis, listening to it, is that a 2-week program it's very brief, but it's also very intense. And it sounded like an old-fashioned, back in the psychodynamic days, kind of intense day hospital or intense hospitalization. It also sounds a bit like a retreat, and that you've got a group of people as patients, you've got a group of staff, and you've really got the family included, so you've created a contextual shift that includes every aspect of the patient's life. And I think that may be part of what made this shift from my symptoms are part of the work I need to do, because they saw it from all the different contexts, the contextual. So what's the plan for follow-up with these people in terms of alumni, 2-month, 3-month feedback and sessions that include family and patients?
Yeah, so thank you for all those comments. We have tried to put it together, and it is very much like a partial hospitalization, and we tried. I think a lot of us tried to help them see that what you might call symptoms are actually also, it's ways that your mind and your body are saying, this something needs to be changed, and that it's okay to feel anxious, and it's okay to also work to see how you can change that feeling, and that you can manage your anxiety, you can feel less depressed, all by the way you think and what you do, and that, people want to help you. I think what was remarkable for lots of them was to come here, and like I said, they came from around the country. So we had 3 from Florida, 1 from Texas. This gentleman's from New Hampshire. And they came here and they saw how much the community was involved. So, the Red Sox Foundation, how much they were supportive of us. And, some of the social activities were restaurants that opened their doors and offered free meals. And for them to see that, like, the community wants you to get better. It was really more powerful than just your wife and your, it was remarkable. So as far as follow-up, as part of this, what's called the Warrior Care Network, we are required to do follow-up, but we've been doing more follow-up than that. So the required follow-up is 3, 6, and 12 months follow, with outcome measures, satisfaction surveys, some basic, typical stuff, what you'd imagine. But we have been in touch with these people, and we had an event where we actually brought them back. So they all came back, all but one came, and were together for an evening, an event that we had. But when they were leaving, we were in communication with their providers that were either they were returning to care with, or ones that we found that were new that we identified. Providers spoke with those providers. So we really tried to help that transition as much as possible. So we're at the 3-month mark actually this week. So in preparation for that, over the last couple of weeks, we've been in touch with them again and letting them know what we're going to be sending them questionnaires and how are things going. And they also know at any point they can contact any of us. I think they have all of our emails and all that sort of stuff, and they have. I had one who emailed me who said, he has a friend who needs, similar help, and when can he get in? So we do try to continue to have that relationship with them.
So I'm just mindful of our time. It's 9:00, and wanted to again remind everybody that we have a wonderful presentation this Thursday afternoon from 4 to 5 in the Shapiro Breakout Room here at the Brigham Women's the Integrative Medicine Research Seminar. And then next month, on February 2nd, please join us again here on Tuesday morning from 8 to 9 for our next case presentation, and flyers are located right here. We want to continue this dialogue, and discussion is not over, so we would invite you to join. I know some of you, there are many other hands in the audience, but if you just right across the hall, we have coffee and refreshments. So please do continue the dialogue. This has been fantastic. Again, thank you to our presenters, and thank you to all of you for coming.